Fun fact, well, I don't know how, some of these like, weren't very fun facts, but I've got 5 daughters, so for you guys,
That's fun by itself.
that's a fun fact there. But my oldest developed exercise-induced asthma when she was 10 years of age, and I think you hear these anecdotal stories about a lot of the Olympic athletes have asthma and whatever. Well, she's a 2-time All-American lacrosse player. All my daughters are lacrosse players. She was a finalist for NCAA Woman of the Year, and she's now currently on the New Zealand National Women's World Cup lacrosse team. So it's doable. Okay, it's for real. So that's the fun fact. Okay, so here we go. All right, we've already know about this. It's a complicated condition. The 2 things that people really didn't get into to any great degree were behavioral. I mean, parents have a lot of anxiety. The kids have anxieties. People who have chronic lung disease, they have a lot of anxieties. Depression's very common with chronic illnesses. That's one of the other dynamics that you have to really take a look at when you're evaluating individuals with asthma or COPD or both. We've got those all both together. You have to understand self-management too. That's the key to the whole thing. I've seen too many case management programs where you come up with the most exquisite care plan, but the individual didn't buy into it. It wasn't person-centered. You've got to really look at that. What's going to work for that situation? And social economics, there's a lot of folks out there that have got environmental problems, but they don't have the wherewithal to do anything about it. Okay? And I look at it, spending tons of money on all kinds of expensive meds, but it's going down the toilet when the trigger is all the molds in the house and whatever. It's kind of like you're getting nowhere. You're treading water, basically, at best. There are numerous stakeholders, obviously the child or the individual with asthma, parents, guardians, the practitioners too, health plans and MCOs. I don't know, some people still view us as heavies. I'm a 501c3 not-for-profit. I do not have shareholders I'm beholden to. I don't have to drive up my stock price on Wall Street. I don't have to pay dividends. Susan's in the same boat too. Our goals are, and I think we're really congruent, is we really want to improve healthcare outcomes for vulnerable populations. We want to address healthcare disparities. This is important to us. For my organization, I'm beholden to that. My CFO says, look, if you can get better outcomes and we can break even, it's a winner. Now, if I were someone publicly traded, that might not be the same conversation, but that's where I'm coming from. Schools are important. We've heard about that. Employers, you can't forget about them. Now, I'm in the safety net realm, but they're commercially insured people out there and whatever. Employers now, for the most part, a lot of them are self-funded. They're paying the tab for the health care. And the thing is, it's in their best interest, I think, to really make the business case to them. Look, it's important for you to get involved because if that parent has to stay home because Junior's got an acute asthma attack, you're going to lose money. You're going to have that kid's parent worried about what's going on. They're not going to be able to focus on what's going on at work, absenteeism, and then there's this thing called presenteeism out there too. That's a huge thing. And then community-based organizations, there's a lot of people out there doing all of really wonderful things. And then governmental agencies, you have them at the federal level, CMS, HHS, and all the other people that were here. State level, there's numerous silos within departments of health. You've got education departments now. There was some mention here about who can provide services and the like. There are some major disconnects. Now you talk about AECs can provide asthma care. My plan's been trying to pay for asthma education. Okay, I've offered it. I've trained practices to do it. The problem you have is their focus is elsewhere, and then before we launched it, we checked with the Department of Education that provides all the licensure here in New York State. I'm not going to beat on the state, and Doug, I don't mean to do that, but the thing is, we were told an LPN who has an AEC cannot provide asthma education. All right, they've got the certification, but it's beyond the scope of his or her licensure. It has to be an RN, a respiratory therapist, nurse practitioner, PA, or a physician, okay? So the thing is, I'm not going to go out and start doing like crazy things to be able to reimburse, and then get someone jammed up with the Office of Professional Conduct or whatever. The other thing with this too is that we've got more than enough work out there, so we got to start having the conversations about what do we do with all these certified health educators out there who have AECs? Why can't they do it? And what I found is, in spite of the fact that we're reimbursing practices to give asthma education, a lot of them don't do it. And the reason why is because the RN's the one that's been told that you can do it, but he or she's got other issues that they have to attend to within that practice, and it just doesn't happen like within the workflows. So those are the other things out there. Local departments of health, they've got different mandates, and some of them have really strapped budgets. I think in Monroe County, one of the counties that we've been in, they focus on anthrax in the post offices. I mean, they really haven't gotten into the public health unless there's a huge epidemic. Okay, I got 1 minute, Penny's telling me, so I got to keep going. All right. So what's innovative? We've gotten involved with the Green and Healthy Homes Initiative, and we're looking at social impact bonds to be able to fund environmental mitigation in the homes of kids with asthma. And what we're going to do is identify the kids of interest, high-risk children, and then work with the community agencies out there to be able to arrange the improvements to the home. And the concept being the bonds would be paid back with what would be called the realized savings. Okay, so it's kind of by avoiding ED use and hospitalizations, that's what's really going to fund the bonds. Well, you've got numerous challenges. You got all kinds of programs out there, care management programs, outreach programs, environmental programs. There's agencies that are focused purely on lead. They see the mold, they can't do anything about it because they're not funded for it. So it gets to be really kind of, well, not comical, but it's almost like a French farce where people are going in one door, out the other, and someone else is coming in. There's a lot of unrelated funding streams, so that's where this term upbraiding, and I'm told to shut up, but I'll keep going here very quickly here. And there's all sorts of potential regulatory issues, which I've talked about. There's also like such a thing that gets into the financing. And as a plan that's reliant on Medicaid, I have to really dance to multiple regulatory players, not only the Department of Health, but Office of Medicaid Inspector General. I can't be using Medicaid funds for something that they're going to view as being inappropriate. Otherwise, I'm going to have a huge problem. So I think what this gets into is that. Also, attribution of savings. Was it the enhanced medication use that really contributed to it? Was it educating the family and getting someone to quit smoking in the house? Was it the environmental change? Those are the key things. So the 3 C's, and that was the title, but we're going to go very quickly here. Collaboration, you really want to get everybody at the table to talk about things, to plan how you want to do it. It's really blueprinting. Cooperation is getting the people that want to actually do stuff together to talk about how you might develop the process. And then finally, the coordination is, okay, if we're in this and we're going to be doing these services, how do I make sure I'm not stepping on your toes, you're not stepping on mine, and we can work in a very smooth and seamless way. It's not insurmountable. It's a lot of hard work, I think, and we heard that like with the St. Louis and the Missouri experience, but it's doable. But I think we just got to get to work, and enough of the talking. Let's roll up our sleeves and really start talking with one another to get stuff done. Thank you.